makes me proud to sort of, again, announce more of our chief residents, a really fabulous part of what we do. I'm going to embarrass Dr. Grova a little bit by also introducing her parents, who we're so pleased to have with us this morning. It's a special time for us to celebrate all of our chiefs who are graduating. We had a fabulous presentation recently from our graduating vascular surgery resident. Monica is going on in the tradition of many out of UC Davis, a proud legacy of our surgical oncology group, to Surg Onc at UNC, and we are very proud of all you've done and grateful for the time you've spent with us. And looking forward to hearing you talk about, I don't know where you got this idea, the alphabet soup of surgical training. So, Monica, thank you.
Thank you. Good morning. I've really been looking forward to talking with you all. The title of my talk is not meant to be a stab at surgical training. I love surgical education and education in general, as my fellow residents know all too well. But when I was reading about the subject, I literally felt like I was drowning in the plethora of acronyms and definitions used to describe the current trends in surgical training. These are many of the buzzwords circling around right now in the education world, and I'm going to focus on just a few of the most relevant at the moment. I'd like to start with a brief overview of some of the things that have caused big changes in surgical training recently, and then talk about where we are right now in training and where we're headed, and then some ideas for future directions. As some of you know, prior to medical school, I spent 3 years as a high school teacher as part of Teach for America. This is where my interest in education really blossomed, and I haven't been able to shake it off since then. I love trying to figure out the learning process and find ways to make people excited and make things stick. And I know you aren't supposed to lead with your best trick, but I only have one trick, and I thought you guys might enjoy it. So here it goes. So I need a little audience participation, so bear with me here. Can people give me some observations? I use this, sorry, as a preface, I use this on the first day of class to help my students understand the difference between an observation and an inference. So some observations about what I'm holding in my hand. Okay, that's all you guys got for observations?
It's white.
Like a candle.
It's white.
It's white? Nice job, Dr. Ali. I think my kids did better.
Unused.
Shape, material, unused, great.
Okay.
Okay. All good, all good. Okay, so keep a close eye on this. Okay, look at the flame.
Wow.
So now I'm going to finish my string cheese. That was string cheese and a piece of almond sticking out of it. And I know you all are far too sophisticated for that kind of trick, but I wanted to show you, just as a reminder, that a dedicated, enthusiastic teacher can really change the whole learning experience. And the learning experience is always changing. I'm going to swallow my string cheese. As the field of surgery changes, this experience of surgical residents are also changing. And some of the big changes in the recent history are due to this 80-hour work week that we've all heard enough about, changes in autonomy, and some of the advances in medicine and technology. So first, the operative experience for residents is changing dramatically with medical treatment of peptic ulcer disease and H. pylori, decrease in penetrating trauma, and the CT scanner has decreased the amount of open laparotomies we're exposed to during training. The ERCP for treatment of biliary disease has decreased our experience with common bile duct exploration, and laparoscopic and endovascular treatments and advances in those technologies have really changed just the scope of operations that we're comfortable doing. The second is the loss of autonomy, and autonomy is another big buzzword in the medical education literature right now. And that's related to several factors, many of which are just out of our control. Things like hospital reimbursement rules and compliance regulations, and then just the productivity pressure, needing to go faster in the OR because OR time is expensive. And those aren't things that we're going to change anytime soon, but I do think it was interesting. I found this graph of the number of TA cases, and a TA case is, you know, as most of you know, but when a chief resident is taking a junior or an intern through a case independently. And the number has dropped dramatically since early 2000s. And I think that's a direct illustration of our autonomy and our independence as well. So the 80-hour work week, as I said earlier, most of us have heard a ton about this, so I'm not going to spend very much time on it. But I thought these numbers were interesting, and they came up over and over, these calculations, and nothing like Sam's calculations last week, I promise. This is my only calculation slide. But the average surgical resident worked 90 to 100 hours prior to 2003. So 100 hours a week over 5 years is 24,000 hours. Now, with our 80 hours a week, we only get to 19,200 hours in the 5 years for a dramatic decrease of 4,800 hours. And they love to make this a big grand statement at the beginning of papers, which is a big deal. It's a whole year. It's a year lost of the 100-hour work week. If you look into this further, there's some interesting things. So there's no change in daytime hours. We're still in the hospital during the day, all day. And then case volume has also not changed. So the number of cases total at the end of the 5 years has not changed. But what has changed is the loss of hours at night, which then translates into loss of independence and autonomy. And I do think that's significant. And while there's no, hard evidence that we're producing lesser physicians at the end of 5 years at this point, it's hypothesized that there can be negative effects on professional maturity, self-reliance, and independent functioning, which I think are really critical characteristics of a competent general surgeon. So in response to these things, the competencies were created, they were created in an effort to increase transparency and accountability and also improve health outcomes. And it's not a new concept, but it is a new concept in medical education relatively. The first competency framework was created in Canada in the early mid-1990s, and then we followed with the ACGME competencies in 2001. As we know from using them in medical school and residency, they're broad. They're broad and kind of abstract, and knowing if you're competent in something like medical knowledge is incredibly hard to standardize across the board at multiple schools or even multiple hospitals. So they're a little bit too abstract to be clinically useful in everyday practice. But if you are interested, there's a 400-page manual you can get on Amazon. It's $179, or alternatively, a DVD version for $99. And I can almost guarantee that no one has even perused these, let alone read them, just as an example of kind of how out of touch the competencies are to us in daily practice. So to expand on these, we created the milestones. And the milestones we are all familiar with here because we use them, I think, twice a year, are 16. There's 16 milestones that are supposed to better define the competencies. And each milestone goes with a specific competency. So for example, medical knowledge. You can be anywhere from critically deficient, which means you don't even know as much as a med student is supposed to know. No offense to the med students, all the way up to level 4, which means you're competent. I have a comprehensive knowledge of both core and advanced surgical diseases. Maybe a good idea in theory, but what we're finding is they're not creating any sort of meaningful feedback for the residents. We fill them out and turn them in, but they're not actually generating a conversation, and they're not helping us move forward with our learning. So the other problem with these is while they're supposed to be competency-based, they're actually still just time-based, which is what we're trying to get away from a little bit. So level 1, that's where you should be as an intern. You check that box. Level 4, that's where you should be as a chief resident. Check that box. It's not actually helping us move forward faster or with any more direction. So enter EPAs, which are called Entrustable Professional Activities. And these really are the next hot thing in surgical education. If you start reading at all, these come up. And just in case you were wondering, I know you guys usually see me in scrubs, but this is what I look like in my head at all times. So have you guys ever heard of EPAs? Just by a raise of hands, has anyone heard of them? Okay, that's actually more than I was expecting. A few. Most of you, no idea what I'm talking about, which is fair. So they were established in 2005 by this man named Ole Tenkate. I don't know how you say that name, but he's from the Netherlands. And in an effort to bring this abstract competency framework into concrete clinical practice. So they're small units of activity. And while competencies describe a person, an EPA is supposed to describe an actual unit of work. And the goals were to improve patient safety. So if you have earned an EPA, you are safe to do that. And also autonomy. Once you've earned the EPA, you can do it on your own. And this, in turn, should lead to more meaningful feedback, supervision, and teaching. So what is an EPA? We don't have these yet in general surgery residency, but they've been applied in many of the other fields of medicine. Here's an example from the OBGYN curriculum that's being created. And they're simple, like you can do a normal delivery, or you are competent to do a high-risk, complicated delivery. And the magic of these EPAs, what people are all excited about, is that you can see that they map to certain competencies. So these are the 6 competencies here, and you have, in this example, 3 EPAs that map to this competency. So by inference, once you've attained these EPAs, you are competent in this area. And so it just takes away the whole need to judge people or give people scores on these competencies that are so abstract. And how do you get an EPA? How do you earn one? And so you earn one by earning a STAR, which is a genius acronym, Statement of Awarded Responsibility, which is kind of cheating because the T isn't really there, but I still love it. So you can go anywhere from level 1 to level 4. Level 1, we all start kind of level 1, level 2. Either you're only allowed to observe if you have a mean attending, you can't even touch things. Or level 2, you're doing it under full supervision. All the way up to level 5, where you are actually allowed to supervise someone else without any other supervision. So you earn a STAR at level 4, which means you could do something completely unsupervised without even an attending, nearby. And that would be the goal. And what is nice about the EPAs is they're not time-based. It's not that you should earn a level 4 by PGY4. If it's a simple EPA, you could be earning that at the end of intern year, beginning of intern year even. And if it's a complex EPA, you might not earn it until 4th or 5th year. So I was interested in these initially because the whole goal is to increase assessment and feedback in teaching, because you have to talk about these EPAs. But I think we're going to run into a lot of problems because they actually count as certifications. They have to be very formally done. When you earn a STAR, that's a very formal thing. And it's been suggested that this requires multiple observations, longitudinal observation by the same attending, agreement between multiple observers, case-based discussions, because you can't, by observation, see every single scenario that might happen surrounding this EPA. And so, like, what if scenarios, like a oral boards type conversation, which for each EPA is quite a feat. So the long-term goals would be, right when you start residency, you know exactly what your goals are. You know what a chief resident should look like and what you should be able to do. And also moving us towards a competency-based certification process rather than time-based. And this is very controversial in medicine in general, but in theory, you could attain all your EPAs and finish residency early. And they're actually doing this. There's a few programs. Toronto for the ortho residency is completely competency-based. And OHSU Medical School is also, their curriculum's entirely competency-based. So they expect 10% to graduate early, 10% late, and everyone else kind of in the traditional time. But none of those programs have actually graduated an entire class yet that has gone through the whole system competency-based. So it's interesting, but some concerns, and these are the concerns just from the proponents of this concept, that haven't been completely ironed out, is what does it look like in general surgery? So family medicine, these are some curriculums that have already been created, and you can see family medicine already has 35 EPAs. So what does that mean for surgery? Are we talking about like 50 or 60 EPAs to define our entire curriculum? And then the increased workload of having to assess everybody on every EPA, it's kind of hard to even imagine. The record keeping and logistics. If you're graduating people early or at random times throughout the year, then what do? Are they going into fellowships? Are they licensed to practice for the rest of the year? And is there an expiration date? If someone earns an EPA second year, does it expire if they don't do that EPA for 2 years, or do you just have it forever? And these are all things that have not been fully ironed out within the system. Then you get the critics. So the big thing is it's not evidence-based. So this framework has been created by experts in the field and expert educators, but there's no evidence that this competency-based and EPA, with the addition of EPAs, has any improvement on patient outcomes or the education system, and it hasn't been proven that it's superior to the traditional model. It's cumbersome, which I can imagine. I mean, we haven't tried it yet, but it seems like it's going to be pretty cumbersome. And it's not truly objective, which they keep talking about. That's the goal, is to make this an objective measure. But if you're talking about what-if scenarios and having these conversations like an oral board, someone is judging you on whether your answers are good or not. So I think that is a big problem, trying to call it objective. And then all this time spent on assessment rather than quality learning is something that I also question a little bit, because really we want the faculty to be focusing on teaching us and moving us forward rather than just assessing us and telling us where we're at. And then the big one, this brings up pretty strong feelings, is that physicians are not technicians, and the competency-based framework was created for technical occupations, not occupations that require higher level or complex thinking. And so there's a lot of feelings that clinical competence cannot be defined just by the sum of these sub-competencies. We're more than that. And you can see, it's not the practice of medicine is not a checklist, and people feel very strongly about this. So I do think I'm interested in how they can be used to improve surgical training, but I do worry that the complexity of implementation could distract from the true goals of actually increasing autonomy and providing us with more meaningful feedback. I don't think we should try to encompass the entire field of surgery in these EPAs, but I think they could be really useful to define a core number of surgical procedures that need stars by the start of your chief year, so that you could practice those independently and be completely autonomous in these maybe 10 or 15 core surgical procedures, because I think that would increase both our competence and our confidence in ourselves when we graduate. So the future. I think there's two things that I think are going to be really important moving forward. One is professionalizing the role of the educator, and the other is deliberate practice. So when I say professionalizing the role of the educator, quotes like this, those who can do and those who can't teach, this quote and the attitude it encompasses makes my teeth hurt. I hate it so much. Can't stand it. But teaching is hard, and it's so important, and it's still so undervalued. And I think whether we embrace the ideas of EPAs or not, surgical training can't move forward without more competent and committed educators. And in surgery, people are expected to teach, but there's very little research done on how to teach effectively in the operating room. It's a good start to fill out the required assessments, but really we need to learn how to drive the performance of that trainee towards that of the expert. And I don't think that that's an easy thing to do, and I don't think we necessarily know the right way to do it. And at the same time, if we don't value teaching, it's not something that can be done in our spare time. And as we know, in surgery, there is no spare time, and as a result, teaching suffers. So I'm just curious from the faculty, how many of you have received any training, formal or informal, on how to be a surgical educator and how to teach or give feedback? Any of that? Okay, quite a few. That's right. So education, I think if we're really going to professionalize the role, and I think we're on, it's going that direction. I think we are going that direction, but we need professional development opportunities, incentives for participation in those, and recognition of achievement when you are demonstrating a commitment to education. And I was also wondering how many of you have actually been observed in the OR teaching? Has anyone? Okay. And I asked this question, it was one person raised their hand. I asked this question because this was a huge part of my development as a teacher. Oftentimes your perception of how you're teaching and then the reality of what your learners are getting don't align. And without an observer or someone giving you feedback about that from the outside, how can we really expect improvement? And that should be everyone's goal, is to be improving. So lastly, I wanted to talk about deliberate practice. An expert performance stems from deliberate practice, and that's a statement from Dr. Erickson in his 10,000 hours work. So that's something that's been in the popular literature, this idea of 10,000 hours to become an expert. But it's not 10,000 hours of just like hanging out next to a llama and being an expert llama trainer by osmosis. It's actually 10,000 hours of directed, focused practice. And I bring this up because I think it's something residents can do on their own. You can start with, self-directed reading, online modules, simulator practice. But then at the same time, the faculty feedback is critical. And Dr. Pierce is an excellent example of this. When I was practicing my FLS, I spent a few days down in the sim lab working on it, that circle cut activity, and was making like incrementally slow progress, not really getting much faster. Circles still looked all shabby around the edges. And then he came in, just happened to run into me and spent about, maybe 15 minutes with me, teaching me how to hold it, use the instruments in a better way. And the results were like ridiculous. So much actual improvement after that when I practiced. I could actually get my times to go down. So I think, as much as the deliberate practice, it needs to be focused and it needs to be directed. And lastly, I just think faculty and residents need to talk more. Dr. Campbell is a fantastic example of this. He talks about indications and workup when we're scrubbing in for surgery, and then talks about the steps of the procedure and common pitfalls when we're in the middle of surgery and afterwards, post-op complications and what to expect for post-op care. So I ask you to teach more and teach deliberately, and to keep pushing us to see what we know. We all appreciate it so much. So thank you to all the fantastic teachers I've had during residency. And a few specific thank yous. Dr. Salcedo for supporting my overly enthusiastic love of education. Dr. Cantor for being such an incredible mentor in surgical oncology. Dr. Galante for turning me back around every time I tried to convince him that I didn't belong here. And then Dr. Trotman and Dr. Farmer for being such strong role models and truly badass lady surgeons. I've had a really full, rich life here, thanks to the support of the faculty and my friends and family. So thank you.
Wow. So Monica, that was really great. And I think, it's the core of why we are here in an academic medical center. It's what distinguishes us from a community hospital environment where great care is also given, but you're right, it gets short shrift often. There's not a great, pay line associated with it, which is one of the hardest things. I will say that the American College of Surgeons is sort of working hard, recognizes this as an issue, and I'm proud to say we've signed up Skeeter for I think we haven't heard yet whether they're taking you in. We've really been bribing them a lot for the new Academy of Master Educators that they're putting together there. So we're hoping that he comes back and brings back all this stuff, and that that the bribes will pay off. But I think you were gentle with us about what we could do. I challenge you, we're all here and friends, I think I've maybe even signed the certificates. How do you really think we could do this better from a faculty point of view?
Honestly, I was thinking a lot about this, like what, the talking more is really, sometimes we can go through an entire day. I can get through an entire day of operations without being asked a single question. And I don't know if that's just because I'm a senior resident now and people just assume I know the answers, but I still want to be asked. You know, I want to tell you that I know the answer. So I don't think it's like laziness. I think it's we're comfortable, you know, and we don't have a culture here of like pushing people. No one wants to make anyone else uncomfortable, which is nice, but at the same time, I know if we were pushed more, there needs to be a push that's hard enough that we're going home every day and slightly stressed and we're reading all the time, and I think sometimes we're not stressed enough here.
So I'm going to push back, and I think people who are over 40 in the room remember the days of pimping. So this got a very negative cultural connotation, and particularly among surgeons, that the surgeons were the worst. That you got pimped in the operating room, you got pimped everywhere. Most places, the medical students complained the most about their surgical rotations, and then it became this whole culture of, are you being abused as a medical student? And you remember, even at UC Davis 6 years ago, we were on probation as an institution, as a medical student. We had a special visit by the regulators about, you know, how much you, and then we put all the medical students in a room and we said, come on, someone must be abusing you. You know, we didn't let them out until they fessed up and said yes. I mean, so we are, I think we as attendings are nervous about it. That we can't do that.
Right,
so
but we
help us with that.
Well, we signed up though for this. Like, we're not the medical students that just happen to be like have to go through the rotation and maybe they're not going to go into surgery. Like, I mean, Jonna went from a med student here to a resident here, so she's like seeing the transition. No, but really, I don't think. I mean, I know that there's. I'm not asking us to turn malignant, but I do think that there's a middle ground there where we can have constant conversations with the attendings about what we're doing. I want to talk about afterwards, like, what am I worried about when I do, you know, this liver resection, or what do I need to be worried about right this second? And I also think that since we do so few like open laparotomies now, or so much fewer, that when we're in there, we need to be talking. We need to be saying like, oh, just so you know, if this was a trauma case, that's where you'd get vascular control of, you know, there, and we don't talk that much.
Okay.
And a lot of the teaching could be done there.
We're good. Let's take some questions. We'll work our way this way. Dr. Hundle, Rossi.
Love the talk, and you're bringing horsepower into the subject that many of us don't have. That experience of teaching students at a very impressionable level is tremendously valuable. Many of us some of us in the room remember the era when we went to lectures for the joy of inquiry and learning instead of a CME credit,
And the money.
and we thought that making the educational process a bit more structured, professional, almost industrial would in fact make it better. We imported a ton of experienced PhDs in the area of education into the system. And just speaking for myself, I thought we'd be a hell of a lot farther than we are right now.
Interesting.
And I'm amazed that we're not. We've made a tremendous investment, mostly experimenting with your education.
Right.
And I'm really not sure it's paid off.
Yeah.
I think many of our residents, if they were fueled simply by the joy of inquiry and learning, would probably be where they are today. So anyway, I'm interested in your thoughts on that perspective.
Well, I did notice, so the EPA guy, this Tenkate guy, is a PhD in education, which I thought was like really interesting. He's not in medicine, and he's literally changing the entire way we're going to be doing things. So I hope he's done a lot of observing and spending a lot of time in the hospital, because I just practically trying to translate things that a PhD in education thinks would be a good idea, and then practicing them in the midst of patient care. Because I really think most of us, that's our priority, is patient care. Our education is important. We obviously need that. But once you're in the middle and in front of a patient, you're like, that's the priority. So those have to match up.
Dr. Grossi?
Monica, it's a great talk, and I think it's something that is often overlooked in surgical, in our surgical life. I have two questions for you. The first is, I don't think anyone really thinks that 80 hours a week is not enough time. That's a lot of time. But I think that one of the things that's really happened, and I like to harp on this, is that it's really, I think being a surgical resident now and learning is much harder than it was when we were here a lot more. And part of it is that it's akin to seeing a movie in pieces versus all at once.
Mm-hmm.
And sometimes different movies. And so my question to you is, what do you think that should be done about your ability to see a patient from evaluation through an operation and postoperative care while maintaining an 8-hour work week? So that's sort of my first question. My second question is about directed practice, which I think is really critical. If you look at anyone who's done anything at a high level, whether it's a sports, whether it's an athlete or a musician or whoever, the kind of practice they do isn't absolutely, tying knots on the tiger scrub. They sit down and try and recreate the situations they have to perform. And I'm curious as to what you think that we should be doing to try and improve that kind of situation for residents.
Yeah, I think those are both good questions. I think it's hard for me to answer the first one since I've only been in one system, like I've been here for this 80-hour work week thing. But I feel like, especially as I got to be more senior, I wasn't leaving. I don't leave if someone's sick.
Right.
I don't think I'm getting a piecemeal view. As an intern, when you get kicked out at 10 or 9 a.m., yeah, that's annoying, but it's also you still have 4 years after that where we can choose. And I think most of us choose, if you have a patient that's in the ICU that's sick and things are happening, most of us don't just sorry, I have to leave. I mean, most of us are staying through until they're stable or finishing the operation, even if we've been there for a lot of hours. I don't think we're truncating our own learning in that way, at least not when we get to be senior and we have that choice to stay and learn through a patient. Because I think you're right. It's really valuable to see the entire thing play out. But I think it's a whole nother problem, the workup. I really think we miss the workup. And I don't know how to fix that because we need the OR time to learn, but we don't see what was done in clinic oftentimes and what you guys, all this background work that you do to get a patient to the OR. But that's a whole nother, could be another topic in and of itself.
But that's where we could talk more about that piece.
Well, I think some people think that we should leave the ACGME as a specialty and do our own certification.
That surgery should leave the ACG.
Yeah.
Yes.
And maybe the board should be the body that governs our education,
Mm-hmm.
as opposed to non-interventionalists,
Right.
who
It doesn't.
really their concept of disease often is in the course of days, weeks, months, years, as opposed to seconds and hours.
Mm-hmm.
And it can be really different in terms of your experience as a learner. To even if as the more senior you become, you actually technically violate your work hours, right, to stay because it's one in your best interest and the patient's best interest. But one can argue that the rules should be different for interventions.
All right, Paul Fan.
So I have two comments. One is with a medical student, regards to medical students, they love to be asked questions. My interaction with the students is that when they have a good experience when they're asked about questions. So it's different than pimping, where the classical definition of pimping is successive questioning to the point where the trainee can't answer the
Right.
questions anymore.
Right.
I think that should be gone. We should never do that. But asking questions and allow them to think and allow them to come up with an answer, I think that's really valuable. So that's different than pimping. And they like to, they like being asked questions. The second comment I want to make about the EPAs is, I think the way that our clinical rotations are organized, so residents go to a service for a month or two, and then they go to a different place. So they don't really have a chance of being evaluated fully or a skill set fully. So EPAs is sort of like a good way for different people, different faculty to look at the individual residents and sort of have a standardized way to evaluate a some of the surgical programs in the United States out there are already doing EPAs for some of the core surgical procedures, like lab chole, for example. You can go to Kaiser, you can stay at, on a trauma service or the GI service, and at least you have a standardized way of evaluating a resident. So that would be a way for us to, I think that would be a good thing for us to do.
And I guess the reason why I said we should talk more rather than we should get more questions asked is because I actually think for someone that hasn't thought a lot about education, sometimes just coming up with questions all the time is really difficult. It's not that easy to think of like lots of questions to ask, and sometimes just talking through the operation, what you're doing, is the easy thing to do. You're already doing that in your head, and if that could come out loud for us, we would love it.
Yeah, Dr. Owen in our research sort of education research group is proposing a way actually to do that. So he's thinking of like the way that we have a checklist in the OR to go through every patient. We have a education checklist where before you start a case, you ask the resident about the workup. You ask the residents about the plan for the day. At the end of the procedure, you have a checklist. You say, "Can't you already, discuss what we brief for the resident what to do?" So that's what Dr. Owen is proposing that we should be doing. At least start out with do some studies with it. Some people out there already are actually come up with applications on the phone to help them go through the checklist. The resident actually also evaluate the faculty by going through the application, and they also have to self-reflect on the procedure. After that procedure, how did I do on that procedure? Was I independent enough, or was I not independent? That kind of stuff. So self-reflection also helps with learning.
So we're going to go Trotman, Hallaby, Satter, Salcedo. Just to make a plan here.
So I have 2 comments and a question. So my first comment is that it has been such a joy to see you develop from someone who was sort of undifferentiated, not sure what you wanted to do with your life and whether even surgery was for you, to someone who really has found their focus in their home in surgical oncology. So I wish you well. The second comment is my husband worked briefly in Europe before he came here, and he told me he was in Germany that they had morning report at it was at a university hospital. It was relatively smaller than our program. And he said every morning they would talk about every patient that would come in. I said that could never happen at UC Davis. There's just too much going on. We couldn't do it. Lo and behold, on my new service, acute care surgery and trauma, they do it every morning from 7 to 8 with a phenomenal morning report where every single patient is discussed. And I encourage every division to do this. It puts the third year and the chief in the spotlight. They have to discuss their workup, their exams, their diagnostics, and their plan with the faculty that is critical yet very collaborative with other faculty. I think it's been a real highlight of the program. My question for you also is, as a student athlete at UCLA, as a rower, you clearly had early mornings and you had to study, which is quite challenging. Here, you have been very active in extracurricular with your salsa and everything else, but you still have a very, you still have been very focused on your education, very committed to your patients, and to just becoming the best surgeon that you can be. What advice do you have for the juniors in the room as to how you've done things so successfully in your work-life balance?
I think part of it is that the work-life balance for me makes me happy, and then studying isn't so unhappy. When I come home and I know one night I'm going to go dance, and then the other couple nights I'm going to study, I think for me that balance has been really important. I don't feel like bitter when I'm at home studying. Well, sometimes I am. Jonna's right here, so I can't really lie about that. But we study a lot. A lot of our life is, my sister's always like, you just got home from work and now you have to study more. I'm like, well, yeah, because there's tomorrow coming. But I do think you have to have something extra that brings you kind of some joy outside the hospital, because sometimes the hospital is a really hard place to be. We're dealing with sad things or upsetting things often, and sometimes you need something that just has nothing to do with medicine. For me, that's really important.
So Monica, do you think it's time now to restructure surgical training 3 years can be like a colorectal MIS track, surgical oncology track, or plastics track.
I don't think that's a bad idea. The only thing that makes me worried about that is like, where's the general surgery track then? I still want that to be a thing. Because
it can be a general surgery.
Right. So as long as that doesn't, take away from what the general surgeon gets to know. I mean, I think part of why most of us went into general surgery is because we want to do that. We want to be competent general surgeons. And I worry already, with all the integrated programs, that's a discussion we're having. We lose our vascular experience, and we lose our, if we had a colorectal fellow, that experience would be so much different. There's, we still want those. I think they're really important for training.
And to comment, a lot of what I learned and what I know is because I operated with surgeons during residency and fellowship. But also, what I know, a lot of it too comes from surgeons I've never operated with. And it's basically watching videos. And like every time almost every day when I sit down with my kids, they're having their model or something, I look at my phone, go on web search, or on YouTube, or on any other website that posts surgical videos. And I watch like different ways of doing procedures that I do commonly.
Yeah.
And I still learn a lot. It's an ongoing process, and I encourage the residents to watch a lot of videos because surgery is all about pattern recognition.
Lifelong learning. No question about it. Dr. Sauer.
Hi. Somebody who shares a lot of the same past experiences and has a passion for education the same way. I think that there's a little difference between being a high school or middle school teacher and being a faculty member in surgical education. And I think one of it is sort of also learner responsibility. I think we as teachers is really important, but I think there's a change in education for learner responsibility versus those that are, very impressionable and that we've decided that their education is the most important. And I think that if you could comment, I think probably as somebody who talks through the OR nonstop, for anybody who's ever been in there with me, I basically don't stop about what it is that we're doing, why we're doing it, and such, is trying to, within the 80-hour work week, getting people to show up. Because it's really hard to teach when people don't show up. And offering people to come to the OR and not, whether it be an intern or a chief or such. Do you have any comments on that as sort of the other side of this that goes with learning? It's really hard to teach people if they're not there.
People should be showing up. Who's not showing up to the OR? I don't know what that's about. Honestly, I think what you're saying is just the learner responsibility. I don't think, as an intern, I remember being very overwhelmed with that. You are on the floor trying to take care of your patients, and of course you'd rather be in the OR. But one thing that I think we should encourage the interns to do more here is do their work in the OR. Even if there's a lot going on, once you've done everything you have to do on the floor, come sit in the back of the OR, and if you have to be on the computer, at least you can hear, and you can come over and look. And then as soon as you're done, you can scrub in. And I think part of it was just like, I didn't know that was okay, but
That's okay.
Yeah, and just come be around. The more you're around, the more the attendings know you, and the more they'll be like, yeah, it's fine, it's in the middle of the case, but scrub in, I know you've been working back there this whole time. But we should be there. We should be using all of our OR time to learn.
So Dr. Salcedo, who is about to take on a much bigger, more prominent role in our educational system here at UCDUs for residents, we'll get you the last question word.
Thank you. I have a comment and a question. The first comment is I want to thank you very much for your tremendous work with just really taking the educational curriculum that we have for the residents here, like really by the horns, and just helping it evolve at a faster rate into something that I think is something really to be proud of here. I also want to thank your parents has something to do with the fantastic woman that's presenting here today. So I think you have earned a bit of the spotlight today also. My question is, as you're probably one of the most experienced educators in this room, and I'm glad that I got to dovetail a little bit on Dr. Starr's comment, because she correctly points out that there are differences between teaching a bunch of super energetic and maybe unruly kids in a classroom in an inner city. But I think a fair statement could be made that it's not all that different. And Dr. Trotman has already kind of made the astute question to ask you to advise the junior residents. But I'm hoping you can give us, as faculty, some advice based on your experience with a highly energetic group of learners and how to focus them on something that maybe they don't even know is for their
Spring cheesing.
Yeah, just light things on fire and eat it. I think so. I've spent a lot of time thinking about that in like the surgery school realm, because it is really hard. Like, we're all self-directed learners, but like no one does their quizzes. You know, like we don't have time to just do things that we don't think are really, really valuable. So I think there could be, but we are self-directed. We all want to be great surgeons. So I do think that there could be more just direction. And that's kind of what I was trying to allude to with the FLS example, is as soon as you tell us how, we are there. But sometimes it's really hard for us to know how. So if there is like a great video site that you go to watch, like tell us, we want to see that video before we scrub into that case too. And if there's a certain article or book that has a great chapter that will help us with the week, tell us that, because we will definitely go read it. But it's very hard. I had a really hard time with this as a junior resident. Like, you go home and there's 100 things that you could read about, and so many things that I don't know, and I didn't even know where to start. I would just be like, well, should I just start at the beginning of this textbook and just start reading? I don't know. What's the best place to learn operative steps? So I really think just with a little bit of prodding, we are unruly, and people want to be doing a million things, but if you can just give us like a direction, we'll go.
Almost like a learning roadmap.
Yeah. And it's different on every service and in every day. It's different. So anything you can give us will help us go.
Well, this is great. Thank you again. And
Thank you so much.